Thank you very much, and it's just a wonderful honor to be here. It's an honor to be amongst friends and colleagues, and particularly amongst a group of individuals who I respect so much, and their opinions I really admire. So I hope I do justice to all of you, and especially all of the students, and particularly thank you, Judith. Thank you, Ryan. So what I would like to do, if you'll allow me, is to speak very briefly about my experience last year and what I've learned about our healthcare system and how it's changing. But where does that fit in with the issue of equity? And so the point I'd like to make is this is an ideal opportunity for us, an opportunity and a responsibility for us to take a leadership role in the issue of transforming our healthcare system to make sure that it is truly equitable. Then I would like to talk about some of the reasons why that might be, and talk about some of the social determinants of health, which all of you are very familiar with, but just to highlight some of them. And then talk about my experience in trying to deal with the most vulnerable within our community, and that's in Ottawa, and end with some of our expectations that we would have of ourselves individually, the organizations to which we belong. So I'll begin by saying that what healthcare is in this process of transformation, and it's being transformed because we're having to reconsider the concept of healthcare as a public good, as a public service, something that we all believe profoundly in, and is something actually that is essential to Canadians as they identify it as one of their core uniting values. However, there have been increasing pressures for us to consider that within the context of a business model. And the degree to which we're successful in the future will be the degree to which we are able to do that. So, let me explain why. As a social good, I don't have to tell you about it, it's built on essential Canadian values, and of course equity is one that poll after poll, when you talk to Canadians what are important to them, they identify equity as an important feature that brings us together, a uniting value of Canadians. But it's built on shared risk, the common good, and the issues of social justice. And as professionals, we reflect that through our values of compassion, respect, trust, and the primacy of patience. Well, I'm a bit leery to talk about this in the context of two very eminent colleagues who are economists, but I have to say that healthcare has been viewed as a drain on our economy, when in fact it's an enormous driver of our economy. Why is it a driver? Well, it employs as many people as the construction industry. It provides us a competitive advantage. If you happen to be in Detroit and you work at GM as opposed to Windsor in Canada at GM, well, that's a $6 per hour competitive advantage that Canadians have. Well, that's a significant amount if you're GM. More likely that you're going to build cars this side of the river. Matter of fact, GM spends more money on healthcare south of the border than it does in steel for their cars. So this is a very important competitive advantage. Having people working as opposed to drawing social assistance, paying taxes, that's an important part of our prosperity agenda. And of course, that aspect of technology and innovation driving through biotechnology our economy. So there are many reasons for us to think of healthcare as an important driver for our economy. However, we have to make sure that we deliver those services and provide value for money that Canadians expect from their hard-earned dollars. This slide just basically highlights some of the concerns that have been emerging that we've all heard over these years about healthcare, how it is falling short of the expectations of Canadians. The system is inadequate to meet 21st century needs. We have a model of acute care, curative medicine, hospital-based, when in fact, perhaps we've been victims of our own success, but in fact, the majority of the circumstances of care delivery occur or should occur outside of a hospital, and they're chronic diseases. We've been now able to manage many of these earlier diagnoses that used to be lethal and now are chronic illnesses. And how we deal with it, how we adjust, is going to be very essential to our success in the future. Many of the principles of Medicare are not being met in this conference about equity and access. Well, we do not have a healthcare system that is fundamentally provides equity and access, whether you happen to be in a rural and remote setting, if you happen to be poor, or if you happen to be in a homeless shelter. If you look at our performance, we expend an awful lot of money in healthcare, $191 billion. That's a lot of dough. Yet, if you look at the services when we compare to OECD countries, we are a top of the pack payer, but in terms of the variety of services that are provided and the quality of those services, we're in the lower 1/3. So the value for money expended equation, we don't do very well in that, and Canadians expect better. So, and then my next point is the physical challenge faced by government. So we have to fix healthcare, yet we're going to do it in the context of tremendous physical challenges, and of course, yesterday and later this week are going to be examples of that. It's going to require a massive change in the way that we deliver services. We're going to have to think of efficiency and productivity, quality of care, and we have to rebuild Canadians' confidence in a system that unfortunately has been struggling. We've heard so much that healthcare is not sustainable. It's not sustainable, I would agree, but it's not necessarily not sustainable from a financial model. Yes, we spend a lot of money. Yes, it's growing at a fast rate, much faster, 7%, much faster than our economic growth. So I understand those elements. I feel it's not sustainable because it's not delivering. That's why it's not sustainable. So I'd rather not look at this sustainability issue as just taking more money out of a dysfunctional system and making it more dysfunctional. And guess who's going to pay the most? It'll be through inequity. The people who, if you take more money out of our existing system, it's not, and from my perspective, as likely that it's going to be the middle class and the rich who suffer. It's going to be the very poor. I would argue that sustainability is universal access to quality patient-centered care, adequately resourced, delivered across the full continuum in a timely and cost-effective manner. So that marries the need for us to transform our healthcare system to make sure that Canadians really do have an efficient, well-governed, well-managed healthcare system. That's true. But we want to make sure that it delivers quality for the population that we need to serve. I'm just going to end with this point, first and foremost, but to say the first 5 principles are the principles of the Canada Health Act. We know them very well. And in fact, I could argue that since 1984, these are just as relevant as they were back in 1984. I would really like it if we actually, delivered on those principles, but they're pretty good. However, healthcare organizations have bought into some new modernizing principles that perhaps would help us guide a transformed healthcare system. And you can see there patient-centered care, quality, health promotion, illness prevention, and yes, equity. And then, of course, sustainable and accountable. So these principles, it's very hard to get, Kathy would know, 2 doctors to agree on one thing at one time. Generally, if you have 2 doctors in a room, you have 3 opinions. That's generally what my perspective is. But all of the CMA, all of its provincial affiliates and territorial affiliates have bought into this. Not only that, over 200 other healthcare organizations have bought into these principles and put them in front of the provincial ministers, in front of the premiers, and in front of the prime minister, and said, we want a new healthcare system, we want it built on these principles. So the reason for showing you this is that equity this is the opportunity for us. This is the time. We know we have to change our healthcare system. Let's build that healthcare system in a much more equitable fashion and make equity a founding principle. We asked many different people over this last year what they felt about their healthcare system, what they would like to see, and this is what the public told us. And They wanted a publicly funded healthcare system, they wanted this expanded scope, etc. But they really wanted us to, and repeatedly said, we want you to start to think about the social determinants of health. We're increasingly concerned that inequity is leaving our communities much sicker than it should be. This came right across the country. Every meeting we had, the public spontaneously said equity was a problem for them. This is without prompting. Those people who were there, 4,000 face-to-face individual meetings, individuals identified equity and the social determinants of health as a priority. Then we had an advisory panel that helped us look at how we could actually take that vision and move forward. And they had many suggestions. I've outlined them, but I just wanted to highlight number 2 here. Inequities in access, major problem. Other countries do better and provided a broader range of services to all citizens. We can do better. They also went on at the end and said, our last point is support services addressing the other social determinants of health. Address equity. So not only did we have the public saying that, but we had many distinguished experts saying, if you want a new healthcare system, build it on those principles that you have and address the issue of equity. So what are we looking at? We're looking at not further picking at the seams, if you will, or a little bit of a change here, hoping that it'll lead to significant changes elsewhere. No, this is a more dramatic change that we're looking at, a transformative change of our healthcare system that's before us. New models of care, scopes of services provided, different governance and management models, more accountability, and financing and sustainability would be key priorities. And in doing that, we have to move from provider-centered care to actually thinking about our patients within our communities. Move away from acute care to chronic disease management, individual isolated practices to group-connected, team-based, accountable practice. Get away from rhetoric and drive this change with evidence. Get rid of our existing siloed system to an integrated regional system based on, as best we can, integrated care, and unrestricted growth of technology, which we've currently had, to evidence-informed innovation. So in summary, on this part of what I'd like to leave you with is healthcare is changing. It must change. And we must shape that change. And it's our responsibility to shape this change to make equity a central tenet of any healthcare system in the future. So that's the first point that I would like to leave with you. And then the question you might ask, well, why? Why? I mean, why bother, really? Well, I think equity makes good social policy, but I think it makes good financial policy and good economic policy. And I hope my colleagues don't murder me later on, but that's the premise I'm going to leave you with. I don't think we can afford not to address a growing inequity within our society that's costing us so much. So I'm going to begin with talking to you about something you all know about, and I'm only going to go over this very briefly, but to highlight to you the inequity that we've seen within in our communities. And this is the slums of Mombasa, where I've worked. We've known about the social determinants of health, and we've known about the influence of those other factors that affect healthcare more significantly, or health more significantly than the healthcare that we provide. What we didn't know since 1967, when the Whitehall Studies 1 and 2 were produced, what we didn't know was just how strong the association was, how robust in every study we look. And we didn't know that the fact that this was an association, but it's most probably causative. And we didn't know just how much poverty played a role. And I'll try and explain that in a moment or two. So the issue of social determinants of health, the recent Senate report from Dr. Wilbur Keon said that of the health outcomes of our community, health care itself only contributes about 25%. 75% comes from other factors outside the healthcare sector. So that's a pretty significant thing. So is it really causation, or is it just association? Well, we don't know. That's the end of that. We don't know. However, the association is so strong, so robust in all factors, in all communities, that it really does seem to be more causative. At the same time, we know that there's a treatment effect. The more poor you are, the prolonged period of poverty, the exposure of poverty at the time of childhood, all of those factors make the health inequity worse. So there seems to be a causative component to that, a treatment effect. So the challenge that we have is that education, yes, poor education causes bad outcomes in terms of health, but so does unemployment. So does poor early childhood development, and many more. But they all interact, and they all come together in the context of poverty. It's very hard to think of somebody who's profoundly poor, living in a sheltered environment. I mean, I have children who are grown to now to the age of 6 or 7 who have lived in a shelter their whole life, get up every morning and go to school. So it's very hard to think of those people who have had normal early childhood development. Their parents are not employed. They're within the 12% of our population that are living in a circumstance of poverty, those children. So all of those confounding variables, all of them interact in an intricate web, and we can't separate out and say which part is poverty, which part is education, which is employment, and all of that. So it is very, very difficult to try and think of our usual causative models, isolate the variable, determine it as a risk factor, and minimize that risk factor. So that is our challenge. Nevertheless, the fact that we have such a strong association leads us all to believe in all probability that poverty and its other confounders are related to bad health. And let me explain that for you in a minute. Now, I've taken a page out of Roy Romano's book, or a report, and I'm just going to highlight 6 areas of some of the social determinants of health. And I'm going to try and make an argument to you that what happens is that we take individuals in our community who are vulnerable, because perhaps of many different reasons, addiction, disability, poverty, whatever it might be, and we isolate them. And we socially stratify them in an isolated environment, whether it be supportive housing or Regent Park, or whether it be in a homeless shelter in Ottawa or an Indian reserve in the north. But we isolate them. We expose them to greater risk in the isolated environment, and then we're surprised that the outcomes, in particular health, are worse. That's not too surprising to me. You put somebody at the Shepherds of Good Hope in a 70-bed room, and you have children growing up in that environment. 15% of that population have psychiatric disease, 40% have addiction. And do you think that those people will have the normal get up and go out and get a job and recover from their circumstances? It's impossible. So saying get a job, it's those people just sort of cannot just get a job. So we put them in that environment where they're vulnerable, perhaps because of their HIV, and all you need is one person with tuberculosis, all you need is one person with H1N1, and everybody has it. So let me talk about this. So don't be hungry. The world's increased its production of food in it's 1975 by 3-fold. And so it's not our inability to produce food, it's our inability to distribute food. So this is the market in Nigeria where I've worked in. And just outside of that, about 40 miles, the incidence of malnutrition in the adolescent population is 40%. 799 million people worldwide are considered to be malnourished. But from where I work, this is about on the right, you're right, it's about a mile from the Parliament buildings. This is King Edward in Murray. There's the usual individuals. We serve 300 to 400 meals a day. In Canada, 868,000 people used a food bank last month. 1/3 of them were adolescents and children. And it's impossible to meet the usual Canadian food guide requirements for nutrition in that context. First of all, have to have a kitchen to do all of that stuff. So many people would recognize that meeting the usual nutritional requirements of a Canadian is very, very difficult, not only because of impediments because of just not enough money, but impediments because of a lack of infrastructure. Live in a nice community. That's good. This is a place where, in Dhaka City, I don't know if you know Dhaka City, it's the capital of Bangladesh. Bangladesh has 130 to 140 million people in it, the size of New Brunswick. Dhaka City itself has got 14 million, we think. There's 5.7 million of that population, 14 million, live in slums, just like this one. This is one of 700 slums in Bangladesh. And I like this because it's a wonderful opportunity to demonstrate. It's nice because they wonderful hydro, and they have this beautiful sort of swimming area outside here. This is actually a sewage lagoon. These are latrines, and they don't have hydro because they have no access to any infrastructure. There's no hydro, no water, and no latrine systems. It is not surprising that in Bangladesh, cholera and dysentery devastates these communities. And so the poor, like I said before, we're isolated, increased risk, and suffer the consequences as a result of this. But here, this is Majors Hill Park, just outside of Ottawa, or just within Ottawa, right, by the West End, right behind the West End. You probably all walk past it. It's called Listerine Hill for those of you probably not walk by that place again without knowing that it's, or thinking of it as Listerine Hill. But at any rate, there's 450,000 Canadians every year who live in a shelter. There are 1,200 that will be in our shelters tonight in Ottawa. There are another 450 who are unstably housed. There are 3.1 million Canadians living in substandard housing. The list goes on and on. But housing is a very important predictor for health. Those people, anybody here from Hamilton? Yeah, that's right. So the richest area in Hamilton? Sure. To the poorest area? How long would that take? Drive. 10-minute drive. The age, life expectancy, drops 21 years in that 10-minute drive. Massive, massive. You think how proud we are that our average life expectancy has gone up by 3 to 5 years over this last decade. We're so proud of that. Just that 10-minute drive, it dropped 21 years. So where you live and in what circumstances you live are very predictive of your health outcomes. I'll move along quickly because this is education. Education is very important for your health. It traps you in an environment of poverty. When in the developing world, we've made great inroads as it relates to education. Unfortunately, those inroads have bypassed sub-Saharan Africa, but they're most prominently in Southeast Asia. If you happen to be on one of our reserves, the likelihood that you'll be illiterate is 1 in 3. The likelihood that you'll be illiterate if you're in the lowest socioeconomic bracket, 1 in 4. That will trap those individuals in that environment and prevent them from moving beyond. Get a good job. Unemployment's a very big predictor of health. We've known that for a long period of time. Some areas of Africa, it can exceed 50%. However, in Canada, we're very fortunate. It varies depending on the year, the month, 6.8 or 8.3, whatever that might be. However, what that doesn't tell you, it doesn't tell you about the 6.5% of people who are underemployed. This person works in our shelter. He gets up every morning. He's a roofer. He just cannot earn enough money to live independently in Ottawa. So he's one of those burgeoning individuals who are underemployed. It doesn't tell you about the single mothers, who 24% of them are unemployed. It doesn't tell you about, if you live on some of our reserves, the unemployment rate sometimes exceeds 50%. So when we look at those numbers, you have to understand that that's distributed in a very inequitable fashion, and there's a great deal of social injustice that relates to that. Finally, this is my last slide, and now I'll talk about healthcare. This is the Nyanza District Hospital. I like to say that when I was there, I go back almost yearly, I was there. They asked me if I would look after the ward there, and this is in Kenya, just near Kisumu. And they said there's 70 beds. I said, oh, that's fine. I can look after 70 beds. And nothing else to do, no meetings. My dean's not after me. And the only thing is that you can see 70 beds, but there's 1, 2, 3, 4 people for each bed. And when I was there for the month, not one person that I saw did not have HIV. So HIV in that community was endemic. Around 19% of the population had HIV. Huge problem. When they were there, they had HIV and tuberculosis, or HIV and dysentery, or cholera, or something like that, but nevertheless they had HIV. This is the shelter environment in Ottawa with the homeless. The incidence of HIV, 21%. If you, amongst my injection drug users, hepatitis C, 80% of my injection drug users. Tuberculosis on a reserve is higher, the rates are higher than where I work in rural Bangladesh. Higher. So the argument that I would have on this is that these social determinants are huge, huge determinants of health. That the poor pay for their poverty with their health. And they do it on a daily basis. And yes, it may be causative. Yes, there's an association, but I think it's strong enough that we should be actually intervening. And so the argument here would be, these are the people who are the most vulnerable. Aboriginals, the rural residents, they're all there, and I've talked about many of them in my examples. But in summary, I'd like to say that the social determinants are inequitably distributed, and therefore it's not surprising that health outcomes are inequitably distributed, so much so that areas within our communities suffer health outcomes comparable to the developing world. And however you might measure it, as one of the areas that's considered to be one of the countries, one of the most wealthy in the world, that is unacceptable. So why would we bother now to equity? Why, turning our attention here, why would we bother to talk about this in a formal way? Well, it's an important expression of our values as citizens. I told you about that. It's an expression of our professional ethics and this concept of civic professionalism, the concept that we've moved from being responsible to an individual, as a doctor or as a nurse, to also having shared responsibility to a healthcare system and to a community. That's civic professionalism. I am going to make the last few moments and say that I think there's a cost saving to be had. And lastly, I think it's a fundamental issue of human rights. So I'm going to very briefly go over this and talk about the high cost of inequity. If we start to look at where our healthcare expenditures occur, yes, they occur in the elderly, but there is a disproportionate expenditures on healthcare in the poor, and they don't get very good outcomes from it. So we're spending a lot of money, disproportionate amounts of money amongst those poor. And when you look at it, we know that 1% of our healthcare expenditures in Ontario go to a small percent, no, sorry, it was 49% of our healthcare expenditures goes to 1% of our population. And yes, some of those are elderly just before they're dying. Many, many more have chronic medical illnesses and are poor. And so why would we want to address these people? Because this is an area of great healthcare expenditures. And this diagram basically highlights the issue of the fact that obesity, diabetes, mental illness, all of those things aren't in just isolated groups. No, they cluster in groups of people. The people with diabetes also are obese, also have mental illness, and also are poor. And I don't think you can cure diabetes or obesity by addressing poverty. But I think you can make a long road towards getting there, and you can make some significant inroads. This is two, very quickly, and I'll go over them. These are two studies, one from the European Union, and they basically looked at inequity. And they said, if I was to look at the issue of inequity as it relates to education, and with a magic wand, could bring those people up to the same level as the population. And perhaps, the logic goes, that I could change their healthcare utilization with that, then you'd save about 20% of your healthcare expenditures in the European Union. The Americans did the same thing and said, whatever it is about the minority status, if I could fix that predictor, and if I could recoup the savings because of the excessive utilization of minority status, how much would I get? $1.3 trillion. In Canada, the estimates have been done as well. They're about 20% it's expected that you would recoup in terms of healthcare expenditures. And I'm going to end by a quick example. And this is the homeless environment that I work within, and I wanted to tell you that we did this because it was the right thing to do, but we also were interested to say, could we actually save money, provide better outcomes, but save money by providing health services in a different way to the homeless? So we knew that many homeless were using health services in a disproportionate way. You take one of my average homeless, chronically homeless people, addicted, psychiatric illness, the minimum healthcare utilization cost, that was not just healthcare, but it was ambulance, fire, 911, and judicial costs from the police pickups. And the minimum of that was $170,000 per person per year, and the maximum was $225,000 per person per year. So if they were getting great care, well, I might say that's expensive, but they're not getting good care. And it's costing us a lot of money. And that issue gets played out repeatedly. So our goal was to try and address that. This is the 1% I told you about. So many people are homeless because they're deinstitutionalized, misguided social policy. We know all of these reasons. Drug and alcohol addiction, it's changed dramatically. I've gone from seeing just exclusively alcoholics now to crystal meth came, crack cocaine came, and now lots of heroin. We see lots of psychiatric disease within our community, socialization, lack of resilience, and here are all the issues that we have to address. And so the bottom line was we felt we could do a better job by actually bringing care to the homeless, because clearly they weren't coming to us, or if they were coming to us, it was ineffective. And so we actually deliver services to them, and we've partnered with 24 different community agencies. Here they're all of the shelters, all of the university, the hospitals, the community access groups, the whole Alliance to End Homelessness. We started off very small. We had a 16-bed wet program, and that's where we gave alcohol to alcoholics. And you might say that we had actually lost our minds around that, but what we were doing was we were giving moderate amounts of alcohol to alcoholics to stabilize them, with the thought that if we were able to stabilize them, I would be able to treat their underlying psychiatric disease, treat the chaos in their life, and then maybe treat their medical problems. And I'll tell you how that worked in a minute. We then had a sort of basically a hospital unit in one of the shelters, another women's program. We have a dying hospice for the dying homeless. And when the homeless became stabilized, all the chaos went out of their life. They started to meet with their families. They wanted to play euchre, and they wanted to garden, have a dog, and they said, we got to get out of here. Remember, these guys are still drinking a drink an hour. I said, I don't want to be around with all these addicts and all this kind of stuff. I'm not an alcoholic anymore. And they wanted to move out. So we bought them a hotel. And that's the Oaks, where that's all done within a chronic housing environment. We have a HIV clinic, now a Hep C clinic. We have dental care for them. We're even thinking of a vet clinic, because many of them have dogs and cats and rats and whatever. We find people out under bridges and fields, and now we're doing an aging at home program for women. So it's grown. So now before I left, I had 210 people, inpatients, on my list. These would be people who would, most of them, not all, but most would be in hospital. And so we provide that care within the sheltered environment. They have complex physical health problems. 95% have severe and persistent mental illness. So we selected out all of the most difficult cases. 95% had addictions. As I said, we've shifted away from alcohol to crack cocaine, opiates, crystal meth, the street opioids, and heroin. And just to let you know that we had an external analysis, an economic analysis, and a health services analysis, showed that 95% had compliance with recommended medical treatment. And I would argue that that's a lot better than this room. 91% appropriate use of the hospital. Now they were going for the right reason. 89% were their primary care was meeting, was accordance with guidelines, and treatment conditions accordance with guidelines, and about 2/3 had a reduction in their risk behaviors in terms of alcohol, etc. And before the program, you can see this is the economic part of it. This is the emergency department visits. This is the police reports. And there was a substantive drop in all areas. And the economic analysis showed that, in fact, yes, you get better outcomes. But did you save money? Well, we saved net of our expenses $3.1 million every year. So you can provide better care, more equitable care for disadvantaged populations, and you can save money doing it. So my last slide, because I want to end here, is to say there's another reason why we should be addressing issues of inequity. Yes, it's part of a Canadian ethic. Yes, it's part of our professional ethic. Yes, it might make even economic sense. But from a human rights perspective, I think it's a reasonable thing to do. I think that all Canadians, no matter where they are, no matter what their postal code, have the right to reasonable health services, to live a life of safety, to have access to education, and reasonable nutrition and shelter. I think that these things are inherent. And in fact, Canada thinks that too, because they've signed on to several treaties demanding other countries to do it. But in fact, they have not internalized that. There is no internal legislative requirement that we provide many of those things for our citizens. And just importantly, it moves the homeless, the concept of the homeless, away from a person who's deserving of charity to an individual who's a Canadian who has access to the usual rights that every Canadian should expect. So why would we get involved? Why do we need to be part of this process? And what could be all of our individual roles in this room? Well, we need information for informed social policy decisions. What better place could help us with information development and policy creation? We need to create a more effective delivery system for prevention and care. Who else could do this better than this group around this table, around this room, within this university? We could be involved as active participants in anti-poverty measures. We could get involved in direct health care. We could affect positive social change through healthy public policy and agitate and force our elected politicians to address the issue of equity. And we could advocate for values that are essential to health and health care, but are also essential for our community. And I think that's where I'll end. I love this quote. I end all the time with this. To be good is noble. To tell others to be good is even nobler, and it's a lot less trouble. So I'll stop. And I think, these are just some very last slides of individuals. When you took those people in the managed alcohol program, you gave them alcohol, they started to do socially responsible things. This fellow on the right, he found out that, his name is Harland, he found out that he had met his family, found out that he had his child, the child was in a hospital, they wanted to fundraise, they went out and fundraised and begged on the street for charity, and they provided all that money. And they do artwork. This guy's work is in the National Gallery. He has 2 paintings. We found him naked in King Edward. And this guy's had 2 vernissages. I'll stop. If people are interested.
We do have time for a couple questions before we hear our next set of speakers.
We're interested but speechless. In particular, we're familiar with the Massey statistics from the third world, but the Massey statistics from Canada are horrifying. How much does an initiative such as you have described depend on a single individual like you? And how difficult would it be to implement similar initiatives in other Canadian cities?
First, we need to repeat the question for our listeners.
So for those listening on the line, the question was, how do we get this done? Is this an individual person just doing this, or are there, could this happen within a broader community without that individual? Well, to be perfectly honest, the things we did, we stole most of that from here. And so I have to be quick to sort of recognize the work that we've got from Seton House and the Annex. And then we went to other places, and other places have come to us. So now there's a burgeoning network of people who are very supportive, and no other place than U of T is creating better information and research in the setting of homelessness. So that's a wonderful thing. But that community is growing. And yes, it does begin with some individuals. But I have to say, looking around this room, many of the people are here and have already done amazing stuff and continue. So I don't think we're short of that. What we are short of is the energy to bring people around and motivate and mobilize the communities to solve a problem. It's very quick, and we've been very quick as we try and isolate the homeless. It's very easy to say, oh, just get a job, But getting a job, saying that says it's their problem. It's their fault. If it only becomes our problem and our problem to solve when we recognize it's an issue that's facing all of our community. And that apathy is a major challenge for us to get over.
Yeah, even more problematic is how do you implement something like this in isolated Aboriginal communities?
Yeah. How do we do this in the Aboriginal settings? And I wouldn't want to think that one size fits all, but the principles are there. The principles are that you listen to your community. We met with all of the homeless people beforehand and said, why do you keep going to the hospital? Why is it ineffective care? And they told us all of the obstacles. We said, fine, we'll provide health care right in the shelters. And so I think this is the ultimate in patient-centered care. This is listening to an Aboriginal community. What are their health care issues? How do we mobilize the right supports in the right places at the right time for them on their terms to solve their problems? And how do we become people who assist as opposed to the ones with the right answers? And I think if we're flexible, we break a few rules, it works. And there's no other community than the one that Roger Strasser works within where they're trying to do just that.
I'm curious about a point on your economic slide where you showed the costs went down.
That was I was afraid of.
There were a few that just shot up.
Oh, yeah. Thank you for allowing me to take a moment to fix that. If I can find it. The reason why that one character, and I blame our economists for this entirely, that one character, who is that guy? That's why I said, who's that guy? And said, I didn't know anybody who did that in the program when we were. Well, in fact, we had a run-in for 6 months where we watched these individuals to do the pre, right? That person was incarcerated for the first 4 months. And in fact, his point, the beginning, the pre, was actually right up here, and the other pre was right up there. But damned economists, they wouldn't allow us to take him out. I said, let's get rid of him. And they said, no, he has to stay there. So, in fact, that person went up because he started up there and came down to here. But thank you for allowing me to give my economist colleagues a hard time.
Jeff, could you do a president of CMA for a year and might add very successful president? Could you just reflect for us on your experience as president, and particularly in bringing these issues to the Canadian public and even that profession? And then finally, what were some of the responses and outcomes to that?
Thank you, James. And I should say I became president at the urging of many of the people in this room, so thank you all, or it's your fault. I don't know what to say, but when I started to talk about these things, it was very, very foreign. And I would be in different places talking about the issues of equity, but I had the usual canned speech that I had to say about CMA and things like that. And they said, yeah, CMA, I would much rather hear about equity. It happened all the time. And matter of fact, So much so that when we created those principles, they said equity has to be one of the key drivers of healthcare. So the CMA actually drove that. Not only that, the CMA, because of the interest in this, has devoted this annual meeting, which will be in Yellowknife, great place for issues of equity, right? And what will be the theme of that annual meeting will be equity. And Sir Michael Marmot will be the guest speaker. There will be papers coming forward and an action plan for Canada's physicians to address the issue of equity in the years to come. So I think it set that stage. I think it was a timely thing to start talking about that. And it took an organization which is pretty darn traditional, I have to say, and it took them a while to get their head around it. But I have to say they are working on it. And I think that the answer to say, when people say, why would we want to do about it? And I said, are you in the business of healthcare? Are you in the business of health? And they would say, yes, clearly, we're doctors. We're in the business of health. Then how could you not be in the business of addressing the social determinants of health and trying to make health for all Canadians better by addressing them? It was a stretch. They said, well, I'm happy to talk about seat belts or bicycle helmets. I think that makes sense. But poverty, education, housing, I don't know. But they're sort of, I mean, they're not experts. They don't want to be the experts. But I think they can lend a voice to that discussion that says, this is important because we see the downstream consequences of it.